All right, welcome. You're in the ICU, and you're faced with that all too familiar problem, the undifferentiated patient with altered mental status. The differential is a mile long. But today, we're going to build a complete, rock-solid framework for mastering one of the most critical, treatable, and frankly life-threatening causes on that list, autoimmune encephalitis. Now, this isn't just about spotting some rare disease. No, this is about you developing a systematic approach, a game plan, for a whole category of neurologic emergencies, where your rapid intervention can literally be the difference between a devastating, permanent injury and a truly dramatic recovery. So, how are we going to tackle this? We're going to use a logical, six-part structure that takes us from the ground up, from the basic science right to the bedside. We'll kick things off with Section 1, the why, getting into the nitty-gritty of the pathophysiology. Then we'll move to Section 2, the what, where we'll cover the clinical syndromes you're actually going to see. Section 3 is the how, a deep dive into the diagnostic workup. In Section 4, the where, we'll focus on what this looks like on imaging. Section 5 is absolutely crucial. It's the what else, all the mimics and differential diagnoses you have to consider. And we'll wrap it all up with Section 6, the now what, which is all about the practical ICU management that you need to know. Okay. Let's start at the very beginning with the foundational science. Why are we starting here? Because if you truly understand the core pathophysiology, it's like having a key that unlocks everything else. It explains the diagnosis, it predicts the prognosis, and most importantly, it guides your choice of therapy. Everything we're going to talk about today builds on the concepts we're about to cover. So, at its absolute core, what is autoimmune encephalitis, or AE? It's your own immune system getting confused and launching an attack against your brain. And it's not just one disease. It's a huge, diverse family of disorders. The thing that ties them all together is this inflammatory process, driven by an immune response that's specifically targeting the brain. Now, this response is often flagged by autoantibodies that go after specific proteins. These targets can be on the surface of your neurons, which gives you that classic encephalitis picture, or they might be on other brain cells, like astrocytes or oligodendrocytes, which leads to these other distinct syndromes we now call things like astrocytopathies or MOG-associated disease. But no matter the target, the presentation is almost always dominated by major neuropsychiatric symptoms. And let's be perfectly clear, these are full-blown neurologic emergencies. A delay in diagnosis, a delay in treatment, that doesn't just mean a worse outcome. It can mean irreversible loss of neurons, and in some cases, a lethal outcome. Okay, this slide right here is probably the most important concept in this entire talk. If you get this, everything else about AE will click into place. We divide these diseases based on one simple thing, the location of the target antigen. In Group I, the antibodies are going after proteins inside the neuron, things like anti-Hu or anti-Yo. Now, the antibody itself can't get inside the cell to do damage. Instead, think of it as a flare, a signal. It's basically telling the immune system that an internal protein, maybe from a tumor cell that looks like a neuron, has been exposed. This calls in the cavalry, the cytotoxic CD8 plus T cells. These T cells are the demolition crew. They see that flare, lock on, and they execute the neuron, inducing apoptosis. This is permanent, irreversible neuronal destruction. And that's why the prognosis here is often so poor, and why therapies designed to just remove antibodies, like plasma exchange or IVIG, just don't work very well. The real damage is being done by the T cells. Now contrast that with Group 2. Here, the antibodies are targeting proteins on the surface of the cell, things like the NMDA receptor or LGI1. In this case, the IgG antibodies are the weapon. They're not calling in an airstrike. They're conducting a direct, reversible denial of service attack. They can cross-link receptors, causing the cell to pull them inside and get rid of them. They can block the receptor's function, or they can even trigger the complement cascade, causing localized damage. But the key here is that the neuron itself usually isn't killed. It's just being functionally silenced. And because it's not destroyed, the process is potentially reversible. If you can get rid of those antibodies, the neuron can put its receptors back on the surface and start working again. This is why these patients can have those truly mind-blowing recoveries, and why they respond so well to antibody-removing therapy. This table, right here, is your roadmap for the cancer workup. It's that simple. If that antibody panel comes back positive for a high-risk antibody, I'm talking Hu, Yo, CV2, Re, or MA2, you have to assume there is a cancer hiding somewhere until you prove otherwise. For anti-Hu, that means an aggressive hunt for small cell lung cancer, so you're getting a CT chest, probably a PET scan. For anti-Yo, you're thinking breast and ovarian cancer. For MAT2, you're looking for testicular cancer in men. Now, for that intermediate risk group, context is everything. A positive anti-NMDR in a 20-year-old woman means you absolutely have to look for an ovarian teratoma. But that same antibody in a 60-year-old man has a much, much lower risk of being linked to cancer. And for the low-risk group like LGI1 or Casper2, the cancer risk is less than 30%. But you still have to look for things like a thymoma. So let's just nail down this first section. First, AE is the immune system attacking the brain, and it's a neuropsychiatric emergency. Second, and this is the big one I'll repeat, intracellular targets mean a T-cell demolition crew, irreversible damage, and poor response to Plex or IVIG. Cell surface targets mean a reversible antibody attack that responds really well to those therapies. And third, the specific antibody you find tells you exactly how hard you need to look for an underlying cancer. Okay, so now let's move on and see how all that pathophysiology actually shows up at the bedside. Recognizing these different patterns, these clinical phenotypes, is your absolute first step to even suspecting the diagnosis and knowing what test to order. The most common way you're going to see this present is what we call limbic encephalitis. And the absolute dead giveaway here is the rapid, subacute onset. We're talking days to weeks, almost never more than 3 months, of a severe working memory problem. These patients just can't form new memories. Their long-term memory might be fine, but they can't remember what they had for breakfast. It's your classic, profound, short-term memory loss. And this is almost always paired with psychiatric or behavioral issues. We're talking agitation, depression, even full-blown psychosis. And seizures, which usually start in the temporal lobes. From your perspective in the ICU, these patients are often showing up with focal seizures that just won't stop, sometimes progressing to non-convulsive status epilepticus, which can be the main reason their mental status is so altered. This whole package, amnesia, psychiatric changes, seizures, that's the core of the limbic encephalitis syndrome. All right, let's zoom in on the single most common subtype of AE, anti-NMDR encephalitis. This one follows a very predictable, multi-stage progression. It often kicks off with some vague, flu-like prodrome, but that's quickly followed by an absolutely explosive psychiatric phase. We're talking severe psychosis, bizarre behavior, just wild stuff. And then it descends into a full-blown neurologic crisis, and that's when they're going to land in your ICU. This phase is defined by seizures that are tough to treat, those classic orofacial dyskinesias, the lip smacking, chewing movements, and life-threatening autonomic instability. Think wild swings in heart rate and blood pressure, hyperthermia, tons of salivation. And then there's central hypoventilation, which can be so profound that these patients need to be on a ventilator, sometimes for weeks or even months. This predictable, step-by-step decline is a huge clue to the diagnosis, and it should make you want to act, even before you get the antibody results back. Now, if you have an older adult, usually a man over 60, who comes in with a rapid cognitive decline, your brain needs to immediately jump to anti-LGI1 encephalitis. This syndrome has a classic triad of findings. First, you've got fasciobrachial dystonic seizures, or FBDS. These are very short, super frequent jerks of the face and arm on one side. That's the fasciobrachial part. The dystonic part is the weird posturing of the arm that goes with it. They can happen hundreds of times a day and are almost pathognomonic, a dead giveaway. And interestingly, they don't respond well to standard anti-seizure meds, but can melt away with immunotherapy. Second, about 60% of these patients will have a low sodium from SIADH. And third, all of them have the core limbic encephalitis picture. If you see this triad, you have to be thinking LGI1. Beyond those big two, there are other antibodies that cause their own unique syndromes. Anti-GABA B receptor encephalitis shows up as a really severe limbic encephalitis with seizures that start early and are very prominent. And more than half of these patients will have a small cell lung cancer. So a positive GABA B result means you're getting a PET scan, no questions asked. Anti-Casper2 also causes limbic encephalitis, but it adds this peripheral nerve hyperexcitability, neuromyotonia, which causes cramps and twitching, plus neuropathic pain. When you see central brain problems plus these peripheral nerve signs, it's a massive clue. Anti-Aglon 5 is really strange. It's this weird combination of bizarre sleep problems, a movement disorder that looks like PSP, and bulbar signs like trouble swallowing and stridor, which can lead to aspiration. And finally, anti-GAD65 is famous for causing stiff person syndrome, but it can also cause tough-to-treat epilepsy and cerebellar ataxia. It's often linked to other autoimmune diseases, especially type 1 diabetes, so you should always check the patient's history for that.
Okay, let's hit pause for a quick board-style question. You've got a 64-year-old man, fatiobrachial dystonic seizures, his sodium is 125, and his MRI shows limbic encephalitis. What's the antibody? It's gotta be anti-LGI1. That triad, the FBDS, the hyponatremia, and the limbic encephalitis is one of the most classic patterns in neurology, and I really want to hammer that home. So quick recap of the syndromes. The main presentation for many is limbic encephalitis, memory loss, and temporal lobe seizures. The most common specific diagnosis is anti-NMDR, with that classic slide from psychosis into an ICU nightmare of seizures and autonomic failure. In older men, you have to remember the anti-LGI1 triad we just talked about. And keep those other associations in mind. GABA-B with severe seizures and lung cancer, and Caspr2 with that extra peripheral nerve involvement.
All right, so you've seen the syndrome, you have a strong clinical suspicion. Now, how do you actually prove it? The single most important message of this whole section is this. You have to act decisively based on your clinical judgment. Waiting for the antibody tests to come back before you start treatment is an unacceptable delay that can lead to permanent brain injury. The Gross criteria are your best friend here. Think of these criteria as your clinical license to act. Let's say your patient has rapidly worsening confusion. That's your subacute onset. You notice a subtle new facial droop. That's your focal finding. Their spinal tap shows 10 white cells, which is evidence of inflammation. And you've reasonably ruled out other obvious causes. That patient right there meets the criteria for possible AE. And that means you have a mandate to start high-dose steroids or IVIG today, right now. You do not wait the 7 to 10 days for that antibody panel to come back. You are treating a neurologic emergency and the clock is ticking. So this right here is probably the most common diagnostic mistake people make. They over-rely on the serum antibody test. For the classic neuronal surface antibody types, like NMDR and LGI1, the cerebrospinal fluid, the CSF, is hands down more sensitive and way more specific. Why? Because it directly reflects antibody production that's happening inside the central nervous system itself. Some labs can even calculate a CSF to serum antibody index to formally prove it, which gives you the highest level of diagnostic proof. A positive antibody in the blood but a negative one in the CSF for one of these key syndromes is a massive red flag. It should make you stop and seriously reconsider the diagnosis. The bottom line is, you absolutely have to test both serum and CSF at the same time. Your other tests, like an EEG, can give you some really important early clues. So let's say you have that classic patient, a young woman with new psychosis and weird movements. You get an EEG, and the report mentions an extreme delta brush pattern. This is a highly specific finding. It's basically this rhythm of slow delta waves with this fast, brush-like beta activity riding on top of it. It's not in every single case, but when you see it, it is a very strong pointer towards a diagnosis of anti-NMDR encephalitis. So let's lock in the diagnostic strategy. First, act when you have a possible AE. Use those Gross criteria to justify starting immunotherapy right away. Second, CSF is king. I'll say it again, for these key neuronal surface antibodies, CSF is way more specific than serum. Test both. A serum-only positive result is a huge red flag. And third, use your other clues. An EEG pattern like the extreme delta brush can give you a strong hint that you're dealing with NMDR encephalitis long before that antibody test comes back. Okay, let's talk imaging. The brain MRI can be an amazing tool for diagnosing AE, sometimes showing these really characteristic patterns of inflammation. But, and this is a big but, it's also full of nuance. And most importantly, it can be completely, totally normal. So let's break down the key patterns you need to know. I want you to burn this quote into your brain. This is one of the most critical takeaways of this entire talk. A normal brain MRI does not, I repeat, does not rule out autoimmune encephalitis. This is especially true for the most common type, anti-NMDR encephalitis, where the first MRI is normal in up to 90% of patients. The diagnosis of AE is made clinically and with lab tests, not with the picture.
Do not let a normal MRI scan talk you out of the diagnosis if the clinical story fits perfectly. But when the MRI is abnormal, you can see some pretty distinct patterns. That classic limbic encephalitis pattern with the bright T2/flare signal in the medial temporal lobes is exactly what you'd expect to see in someone with the memory loss and seizures of LGI1 or GABA B encephalitis. A pattern of patchy inflammation all over the cortex is highly suggestive of anti-GABA A receptor encephalitis, which often shows up with status epilepticus that won't quit. And then there's this really unique pattern of linear radial enhancement that looks like spokes of a wheel coming out from the ventricles. That's the pathognomonic sign of GFAP astrocytopathy. The location of the inflammation on the MRI often lines up perfectly with the clinical syndrome you're seeing at the bedside.
Telling the difference between AE and its most important mimic, herpes simplex encephalitis, is a daily challenge in the ICU. This slide gives you the key radiological clues. If the limbic involvement is bilateral and pretty symmetric, that favors AE. HSE is classically on one side, or at least very asymmetric. Involvement of the basal ganglia is another good clue, common in AE but typically spared in HSE. On diffusion-weighted imaging, or DWI, that bright signal of true restricted diffusion is a hallmark of the cell death in HSE. It's pretty rare in AE. And finally, if you see any evidence of bleeding, that makes AE extremely unlikely and points you directly toward HSE. So to sum up the imaging pearls, first, and I can't say this enough, a normal MRI is common. It does not rule out AE, especially NMDR encephalitis. Second, when the MRI is abnormal, know the patterns. Medial temporal changes for classic limbic, and that weird radial enhancement for GAP. And third, when you're trying to decide between AE and herpes, remember the big differentiators: one-sided changes, true restricted diffusion, and any hint of blood should push you hard towards a diagnosis of HSE.
We've talked about HSC, but the list of things that can look like AE is huge. Misdiagnosis happens all the time, and it can cause real harm. You're delaying the right treatment for the real problem, and you're giving unnecessary, potentially toxic immunotherapy. So you have to keep a broad differential, especially when the clinical picture is just a little bit off. This data from a big 2022 study is pretty sobering. When experts looked back at cases that were misdiagnosed as AE, the most common real diagnosis was actually a functional neurologic disorder. Right behind that were neurodegenerative diseases like CJD and primary psychiatric illnesses. So why does this happen? Well, the symptoms overlap. The behavioral changes in AE can look just like a primary psychiatric problem. The rapid cognitive decline can mimic a fast-moving dementia, and the often bizarre and fluctuating motor symptoms can easily get labeled as functional. This is a powerful reminder of why you have to stick to the diagnostic criteria, especially that need for objective evidence of CNS inflammation, and it shows you the danger of jumping to conclusions based on vague symptoms or a low-level serum-only antibody test. In your ICU, your differential has to include these critical mimics. For Creutzfeldt-Jakob disease, or CJD, you're looking for that classic cortical ribboning pattern on the DWI sequence, and you need to send the CSF for the highly specific RT-QuIC test. You always have to consider Wernicke encephalopathy in any patient with risk factors like alcohol abuse or malnutrition. Look for that characteristic bright T2 signal in the mammillary bodies and medial thalami. And this is so important. You have to be able to tell the difference between the dysautonomia of AE and neuroleptic malignant syndrome, or NMS. If a patient is on an antipsychotic and they develop a fever and rigidity, check a CK. A massively elevated CK strongly points to NMS. This is a vital distinction because the treatment for NMS is to stop the drug, not to give more immunosuppression. So let's recap the mimics. First, remember the most common misdiagnoses are actually functional disorders, neurodegeneration, and psychiatric illness. Second, know your key imaging clues: cortical ribboning on DWI for CJD and mammillary body changes for Wernicke's. And finally, never fall into the NMS trap. If a patient on a neuroleptic gets a fever and becomes rigid, a sky-high CK points to NMS. The treatment is to stop the drug, not to give steroids.
Okay, let's get to the management. Now what? What do we actually do in the ICU? This part is all about two things: aggressive early immunotherapy combined with meticulous, proactive supportive care. Now, I have to be honest, the evidence here isn't from huge randomized controlled trials. Most of these recommendations are considered grade B or C based on retrospective studies and expert opinion, but they are absolutely the current standard of care.
The treatment plan for antibody-mediated AE is a stepwise escalation. You start first-line therapy as soon as you suspect it. This is usually high-dose IV methylprednisolone, IVIG, or plasma exchange. A lot of experts will actually combine steroids with either IVIG or Plex to hit the problem from two angles at once: steroids for broad immunosuppression and Plex or IVIG to physically remove the bad antibodies. Now, if after 10 to 14 days you're not seeing any real improvement, you have to escalate to second-line therapy. That usually means rituximab, which wipes out your B cells so they can't make new antibodies, or cyclophosphamide, which is a powerful immunosuppressant. But a critical pearl here is that you have to be patient after you start these second-line drugs. The time it takes to see improvement with something like rituximab can be weeks, even months, especially in NMDR encephalitis. All right, the supportive care you provide in the ICU is just as critical as the immunotherapy. For status epilepticus, you'll use your standard protocols, but just know that these seizures are often incredibly resistant to anti-seizure meds alone. They'll only really break once the immunotherapy starts to work. For psychosis and agitation, you can reach for atypical antipsychotics like olanzapine, but you have to be extremely cautious. And this is critical. Avoid the first-generation, potent dopamine-blocking neuroleptics like haloperidol. In a brain that's already inflamed and dysregulated, hitting it with a powerful dopamine blocker dramatically increases the risk that you'll cause iatrogenic neuroleptic malignant syndrome. And speaking of things to avoid, this is a huge one. Avoid ketamine in patients with suspected or confirmed anti-NMDR encephalitis. It's a common ICU drug, but it's an NMDR receptor antagonist. The patient's problem is that they don't have enough working NMDR receptors. Giving them a drug that blocks the few they have left can make their agitation and psychosis catastrophically worse.
So what's the big takeaway here? Autoimmune encephalitis has gone from being some neurologic mystery to a diagnosable and, most importantly, a treatable neurologic emergency. For you in the ICU, mastering this means recognizing the clinical patterns, understanding that fundamental split between T-cell and antibody-mediated disease, acting decisively on a probable diagnosis, and aggressively managing both the underlying immunology and all the life-threatening complications. When you do all that, you can fundamentally change the course of this disease and give your critically ill patients the best possible shot at a real, meaningful recovery. The challenge for the future is no longer just recognition. It's about optimization, getting to a place of true personalized neuroimmunotherapy. Type continue for further detail.